310. How are you? It's Sunday. Okay, today is November 16th. Okay, I'm wearing my Saints t-shirt for all you football fans because we want the Saints to win. And if you don't know our cheer, it is who dat. Okay, I couldn't get it right, but that's okay. Everything's asked backwards when you're looking in the screen. Okay, so first of all, thank you guys for doing the survey. This survey you can take as many times as you want. For those who haven't gotten to it, it's right here, okay, on your taskbar. You click on it, okay. It takes you to the survey. You go in just like an exam, and you continue on, and boom, okay. It's anonymous. I don't see who answered what. It just tells me that you took the survey, and that's it. And we've already had 25 people do it, which is awesome. Okay, that's part one. Okay, going back here to the announcements, I did want you guys to know that I've set up the Zoom meeting. So you would go in, again, like you always had here, through Zoom meetings, Monday, Wednesday, and Friday now at 2 o'clock, all the way through the beginning classes. So all the way through Thanksgiving, Christmas, everything. Monday, Wednesday, Friday, 2 o'clock. We'll do why are we doing this? Okay, we're doing this because I want you guys to stay fit and keep your head together, all right? And we're doing it because I'm going to do the core and stretch every Monday, Wednesday, Friday, 2 p.m. So be there, be square. You know, if I'm there for like 15, 20 minutes and nobody shows, then that's okay. That's the way it goes, right? But come join me. You know, it's a good thing to do, all right? And yeah, we've had, you just scroll through the announcements, it just shows you what kind of an amazing class we've had. Okay, don't forget to try the recipes that were put forth. Okay, I'm looking forward to Kevin's cookbook. Okay, all right, sounds like an alliteration almost. All right, maybe the cookbook should be with a K. How's that sound? All right. Okay, so I think that's it. One thing I wanted to do, I felt bad that we didn't finish, so I'm going to go ahead and I'm going to go review through some of the course material that we didn't get to, because it's important stuff, especially when we look at autoimmunity. I've talked to a lot of people in class that they themselves are dealing with autoimmunity, and as well as family members, okay? And it's super important because it should be taken seriously, and I think as future physicians you should know what's going on. Now, in terms of working this out, we're gonna be following the Stackhouse method. Okay, she is an advisor to me, and so this is going to be set up for the No Stress Express for extra credit in your final exam. That again is going to be really cool because it's going to be collaborative, right? All right, cool. All right, so where are we at here? All right, so just let's get rocking and rolling, okay? So it is a big deal, okay? We spent so much time on cancer in this class, okay? And we see this right here that 9 million people in our country at any one time point, if you look, are dealing with cancer. 22 million dealing with heart disease. Diabetes is, of course, is even worse. It's right up there. But look at autoimmune disease. It's 23.5. Okay, and it just really doesn't get the representation in terms of research. Okay, there's a little information from Dr. Fauci that's really big in this section, and it doesn't get the respect from physicians, and that's something that you guys got to change. Okay. And a big part of what I'm talking about in this class, women, okay, have to be strong. Women are number one, and 75% of people that have autoimmune disease at any one point in time are women. Okay, so that sucks. All right. So let's continue on here. All right. So why is this happening? Why women? Okay, women have this unique mechanism of autoimmunity that we're going to talk about. As we get older, different types of autoimmune disease kick in. Okay, that are shared by men and women, because as we get older, our immune systems are altered. The men undergo the basic aging change that we talked about, but women, okay, by going through menopause and not having estrogen down, undergo a major transformation to make them a little bit more like men in terms of their immune function. Okay, awesome. All righty. So we see right here, okay, We already talked about immune aging in this class, okay? We talked about how the cellularity, okay, decreases in your bone marrow, all right? So you have a shrinking of the stem cells, and then this translates like a domino effect. So then you have a shrinking in the number of naive T cells and B cells that are being produced, okay? So you're pumping out these brand new naive T and B cells that hopefully are going to be able to fight off a bacterial infection, hopefully fight off a viral infection, okay? So you get a contraction as a result in kind of the diversity of these types of cells that are out there. And it is a bizarre shuffling of the deck of cards in terms of the surface proteins that are out there trying to recognize all the different bugs that we're constantly being bombarded with, as well as trying to recognize the unique surface proteins of cancer. Okay, so we see here this decrease in T cell receptor sensitivity as well. So that would be intrinsic mechanisms. So nothing gets better as you're getting older. So these would be, the protein kinase cascades that lead to changes. Consequence, you get sick more often, and when you do get sick, you tend to have a stronger infection from these age-related changes. Okay. And then this gets into the unique age-related immunity that happens right here. Okay. And so because of the loss or the reduction in the balance we talked about, so you have both men and women have less lymphoid representation, more myeloid, which is your non-specific innate immune system, all right? So it just goes after critters and it doesn't undergo massive cell division. The lymphoids undergo massive cell division in response to an infection, okay? Alrighty, and as a result, you have a really, really excessive inflammatory response trying to bring in that ineffective lymphoid system, okay? And so herein lies the madness, for example, right now with SARS-CoV-2 infection and ultimately COVID-19, we have this major inflammatory overreaction, okay? For the topic we're talking about right now, we also have, as a result of these changes in the immune system, we see unique failing in certain tolerance to your own surface antigens, and then you produce these unique antibodies. It's kind of a different set of autoimmune diseases that kick in as you get older. Cool. All right. So, like I said, the majority are women. Okay, 2% of men get autoimmune disease, and estimates about 14% of women get autoimmune disease. And then this is just looking at a survey of autoimmune diseases. Certain ones are really high order. We're looking at Sjogren's, which Julie has. It was horrible too, by the way. Joint pain, it took out her vagus nerve to her stomach, so she puked all the time. It was a really difficult disease to deal with, okay? This is systemic lupus erythematosus. So you've heard of lupus, okay? And it goes after, again, lots of tissues, but renowned for going after your liver. And you can see this really heavy weighting towards women. I talked about thyroid disease. This could be Hashimoto's, okay, or it could be Graves' disease. And so look at see all through here again this abnormal balance. Now this is really important, okay. Like I said, 50 million Americans live or cope with autoimmune disease, and it can be very disabling, okay? My take-home message is if it doesn't feel right, it's because it's not right. You guys know your bodies, okay? And so a survey was done through the Autoimmune Disease Association, okay? And approaching 50%, I'd like to say that, okay, 45% of patients with autoimmune disease have been labeled chronic complainers, okay? At the earliest stages of their disease, okay, which is just bullshit, okay. And in addition, the Autoimmune Disease Association found that it took most autoimmune patients up to almost 5 years and nearly 5 doctors to finally get the proper diagnosis, okay. It took Julie 7 years, okay. And just a bullshit story. I remember she went when her vagus nerve got taken out and she was puking all the time. She went to this, male doctor, superior supposedly gastroenterologist at Hoag Hospital, and he did one bullshit test on her, and then he told her, she went back to see him, and she's, look, I'm dying, and he says, he looked her in the eyes, he says, I'll do increasingly more painful tests on you until you go away. That was his doctoring, all right? And I wanted to kill the guy, all right? But she finally had somebody run a CRP test, okay? And instead of being 3 or less, okay, milligrams per liter, hers was almost 8, okay, showing that she had this autoimmune inflammation. All right. Again, this is just looking at male, female. I'm going to drive that into your head, okay? Why the male-female difference? We see here, of course, women have 2 X chromosomes, and that means there's this X chromosome dominance in terms of immune system genes that kick into action and affect the behavior of their specific, okay, immune system, of their acquired immune system, of their T cell population. Estrogens also influence it, and then there's lots. We're going to go over environmental exposures. You know, men, there's the view that they become more tolerant because they like this laying gutters when they're little kids. And then this one I find really fascinating, and that is the fact that we have when you have children, you have chimeras, okay? And so having kids is thought to be a risk for having autoimmune disease, certain autoimmune diseases as well, because little pieces of your child will cross the placenta and lodge themselves in different parts of your body. And they have abnormal proteins because half of them is your husband's DNA. Okay, awesome. So this right here goes over some of the unique genes, okay, right here that are active, that are expressed in women because of the double X chromosome. You have differential silencing in each cell, which, because you have 2 chromosomes, you don't want both of them pumping away. So at any point in time, one is superactive, the other one gets silenced, and that can really, depending on how that works out, you can have problems of autoimmunity. Okay, so right here, okay, so we have hygiene differences between men and women, estrogen versus testosterone. Okay, all right, so so this will have your autoimmunity oftentimes kick in with puberty and going through menarche. Pregnancy is a big estrogen change, and that affects your autoimmunity. And then menopause, again, big estrogen change. And it all has to do with not just the presence of estrogen, but how much is there. Okay, all righty, cool. So again, this article goes into some of the details, and they start talking up here about T1 versus T2 immunity. Th1 versus Th2, and Th1 and Th17. So anytime you see that 1 in it, it is an issue that is more dominant in women. Okay, men have these helper cell lines as well, but women have more of them. Okay, men tend to be Th2. All right, and again, you're talking, the balance with billions of cells. So the H stands for a T helper cell, and they then guide the strength of the immune reaction. Makes it super strong against viruses, super strong against bacteria. Big deal for women. Okay. So men actually tend to get sick more often, say sick longer when they're younger, all right? And so again, here's some reading on this, okay? And well, we look at the balance between Th1 and Th2. And oftentimes when you have Th2, you can actually have anti-inflammatory pathways that kick in, okay? That help protect you against autoimmunity. So these are all things to think about. So when we're looking up here, okay, at our cell lines, okay. Again, these are, remember, we went through bone marrow. We're looking specifically at the specific or acquired immunity system, okay. And they produce both B cell and T cell precursors from those stems, hematopoietic stem cells out of the bone marrow. And then off they go. And on the T helper cell line, which is the big deal for autoimmunity, you go into the CD4 population. That is the 4 is a unique protein that gets, it's called a cluster of differentiation. That's what the CD stands for. It's a cluster of unique proteins on the surface of these cells, and they become the T helper cell line. Okay, we have the CD8s, okay, and then they become, remember we talked about those are the killer T cells, okay, and then the T regulatories are a combination of CD4 and CD25, again, unique proteins on their surface. Okay, so within the T helper cell line, there are different types of T helper cell lines. Like I said, Th2, more male, okay, Th1 and 17, more female, okay. This balance is super important right here, super important, okay? Because it changes the cytokine profiles. Th1 is super pro-inflammatory, and at times Th2 can be anti-inflammatory. It can be pro-inflammatory against your body, okay? So again, Th1 is designed, okay, to drive this super interaction with your antibody producing cells, okay? And then they also drive your killer T cells as well, okay? Super important for fighting off bacterial infections, okay? Women are Th1 dominant, all right? This protects them from infection so they can get pregnant, right? We talked earlier in the class. It's all about pregnancy. It's all about estrogen going bam, 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 right? It makes every month, it sets your breast up so that you are going to be able to feed the child that you just made. And every month it sets up your uterus to make sure through cell division that uterus is primed for an embryo to embed itself in there. If it fails, boom, estrogen dissipates, everything, your breast shrink, that on and on and on. Estrogen also is driving your immune system, okay, protecting you so that you will get pregnant, so that you do not have fall victim to a bacterial infection or a viral infection. The double-edged sword of this is it's so aggressive that it creates a greater risk for autoimmunity. Okay. Alrighty. Now, like I was telling you earlier, this all has to do with the level of estrogen. When you become a super estrogen producer, okay, like now you're pregnant, we got to back down your immune system, all right? We don't want it to begin to attack the fetus that looks, for all intents and purposes, like a big giant bacteria growing in your uterus right now, all right? And so what happens when you have high estrogen is that the balance shifts to this more male-like Th2 immunity, and you don't reject the fetus, okay? It's believed that women that have miscarriages are in part because the estrogen levels didn't kick in to protect them by transitioning from a Th1 to a Th2, okay? Alrighty, so women that have autoimmune disease find when they get pregnant, lo and behold, the autoimmune disease disappears. And it's a beautiful, great time for them, but as soon as they give birth, the autoimmune disease comes raging back, all right? All right, this describes the cell types, again, that we're down here. This is the transition. This is just talking about people, not men versus women. So we're born with a more aggressive innate immune system, specific immune system of the granulocytes that make the macrophages and the dendritic cells. And then as we grow older and go through puberty, then the balance transitions. So this right here is more of a Th2 for young children. As adults, all of us get more Th1, but women get more Th1. And then as we get older, the balance disappears and it makes us super vulnerable to infections. Okay, awesome. All right, so that's what that's all about. Here's some reading. I'm not going to do it. And this is this is kind of like the entertaining, fun part of that. Fun for me, okay? And it shows you this concept of this is you guys growing up in your mom's uterus, okay? The placenta, you have this confluence, okay, where your blood, okay, is able to go in there and give antibodies to your baby, okay, give nutrients to your baby. But what happens is bits and pieces of the baby, you guys, leave the placenta and go in and can get stuck all throughout your mom's body. Okay, and so she becomes a chimera because she's not all just her. She now has bits and pieces of you. Okay, two genetically distinct cell populations in the same individual. That's your mom. Okay, um, and there's even evidence too that it goes vice versa, which is kind of interesting. All right. Now this triggers an immune response in some women. All right. Pretty interesting stuff. Okay. These are this goes into different mechanisms of immunity. Just my recommendation to you is just kind of to go through this, and you know it can happen from you know, again, women have this aggressive immune system, so part of it can be just, you know, you have a cell that dies, okay, and then the woman's immune system goes after those, remember, those damps, and flips out and creates memory cell lines that will forever go after any proteins that look nice in other cells. Okay, so that's no good. Okay, sometimes the cells are just alive and they present unique antigens, and it goes after it. And then other times, you can have like a viral infection that will trigger the same thing. All right, cool. So there's tons, I mean, of autoimmune diseases. Lupus, systemic erythematosis, irritable bowel disease, Crohn's disease, ulcerative colitis are all part of irritable bowel. Fibromyalgia, chronic fatigue. It goes on and on and on, all very real. Okay, these are some instructive YouTube videos. We're going to do multiple sclerosis, MS, in 414, and look at the modulation of that by aging, okay, and in the transition that happens. And again, this goes over what it's like having lupus. Again, it's not just any one tissue. Lots and lots and lots of tissue get impacted. This is classic right here. Here, we can just watch this, okay? Because I love this video, because it's what people have to go through when they have autoimmunity. All right, so let's take a look at this thing. All right, and make sure that I have my sound up. I do. And make sure I have my sound up here.
God does everything for a reason, right? So if you have this disease, he clearly wanted you to have it. I'm just saying. Oh my God. I know somebody that died from that.
Is it contagious?
I mean, I'm not saying you're gonna die. You know, you're not gonna die.
Girl, I know what you're going through, because I had a cold one time and I never thought it was going in.
But they died. They're dead.
Are you still sick?
Is it like cancer? You don't look sick.
My cousin, best friend, auntie, brother had the same thing that you had, and he drank lemon juice for 3 weeks straight, and he was cured.
You know what you should try? Greens. Just like juice them and eat them for 3 weeks straight. I swear it's gonna make you so much better. Not to be rude, but you complain a lot. I mean, I broke my arm like 3 months ago, and you barely heard me talk about it.
Is it like cancer?
Oh my God, you're always tired. I wish I had whatever disease that you had, that way I could be like super skinny. You're so lucky. Are you eating? Is it cancer?
Oh my God, you lost so much weight.
Oh my God, girl, you've gained so much weight.
I know you're tired, but I mean, everybody gets tired.
No, but it looks good on you. Like, you don't look sick anymore. You look normal. It looks good. Stay like that. You're being a little bit dramatic.
We gonna pray it out. I rebuke it.
So what do you have again? At least you're not in a wheelchair and can feed yourself.
Don't play with God. You better be praying with me. Close your eyes. Close your eyes.
Okay, so it's not cancer. You know, it's a mental thing. You gotta like push through it. Oh my God, I think I caught whatever you have. Are you sure you're sick?
Shut up on a Honda. Drove off in a Lexus. Hallelujah.
You're always in the bathroom. Come out. So what do you have? Lupus. You guys have a lot in common. Well, you guys have the same disease, so that's a lot, right? You have to use the bathroom again?
So if you don't have cancer, then why are you on chemo?
Oh my God, Karen, you can't just ask somebody why they're on chemo.
She says she
You're looking at the camera because they're talking to somebody.
All right, and that's the kind of bullshit people have to deal with all the time when they have autoimmune disease. Okay, yes, we do give you methotrexate for treatment of autoimmune disease at a much lower dose than you would give for treating somebody that actually has cancer. All right. All righty. So this again just is going through just a couple of diseases, and this this one right here affects a lot of us, and it's the real deal. It's very disabling. Okay, chronic fatigue, like I said, is very disabling. All right. All right, I just want to get into the meats and potatoes now. All right, how do we diagnose autoimmune diseases? Okay, so first of all, we're looking at your CRP. It's the one that is used most often by clinicians all around the world. It's because it's a very cheap lab test to do. Again, the 3 is the cutoff. Okay, you can also do an analysis using antibody detection for IL-6, IL-1, and TNF alpha, all elevated during certain types of autoimmune disease. Okay, now when you have autoimmunity, okay, you have not only elevation of CRP from the liver, but the liver also will pump out fibrinogen. Okay, it's just the liver is always like, we got a problem, and it just throws everything out there. It throws out proteins important for clotting. Maybe all the elevated CRP is because you've really damaged yourself, and we need to clot. So they throw out clotting proteins, including fibrinogen. What happens is fibrinogen will bind to your red blood cells, okay, and it causes a major acceleration or speed up of the sedimentation rate that we have when we spin your cells down, and so we have this readout of autoimmunity because of fibrinogen binding to the erythrocytes. As you see right here, not very sensitive. CRP is the one. CRP is the best one. Okay. There are enzyme-linked immune absorbent studies. Okay. Again, you would use that for these. Okay. Called an ELISA. There are traditional tests that can look at antibodies that you have. So you can look at rheumatoid factor, and this is not only important for rheumatoid arthritis, but other disease. And then this one right here, which is a surface protein that is commonly has antibodies raised against it. Okay, when cells fall apart, this is a big one. We have anti-nuclear antibodies, and we also then are able to categorize your T and B cells and see if you have an imbalance. That could be a precipitating factor for your autoimmune disease. Okay, all right. I love this little figure right here because it just kind of shows you what happens when you have an infection. Okay, and we look at the response to what's going on. Okay, all right. So I'll blow this sucker up. Okay, whoop, and I'm going to move my thing out here. Where's it going to cut? Paste. Oh, not that one. All right. Cut. Paste. Boom. Okay, there it is. Okay. So this is just a measure of basic proteins in your blood over a 21 period time. Okay. And then we're going to look right here at, again, following an infection, what happens. You see the liver goes nuts. Okay. So you put out this C-reactive protein. Amyloid is another one that gets produced, okay? And then I talked about fibrinogen right here, okay? So this is the phase response of an infection, okay? I just want to put that out there. All right, so how are we going to treat your autoimmune diseases, all right? Steroids is a big one, oral steroids, okay? Oral prednisone, what it does is it inhibits T cells. Remember, women were T helper cell 1 and 17 heavy, so it works to slow the roll of T cells, okay? All good, but no free lunch, okay? It also, because of this, is going to inhibit your immune function so you're more vulnerable to infection, and it can become a risk factor if you do too many steroids for having diabetes and heart valve problems and things like that. All right, cool. All right, the traditional thing is just using Advil, ibuprofen. I like Celebrex. These are non-steroidal anti-inflammatory drugs. Okay, I just got a surf report. Too bad. I'll turn it off right here. And then we start stepping up our games. These are the more aggressive type of treatments. There's a category called disease-modifying anti-rheumatic drugs. the mechanisms sometimes are just kind of more theoretical. And then we have the biologics that we talked about in class. We talked about TNF-alpha. Okay, remember IL-6 in the Emperor of All Maladies. Okay, so we can infuse. These are antibodies. We have to infuse them once a month. An antibody that is raised against TNF-alpha and an antibody raised against IL-6. Okay, or we can use protein kinase inhibitors that are, and this particular protein kinase, the Janus kinase, remember back then, in that previous slide, is highly expressed in our T's and B cells, and this will slow their role, okay? And then lastly, we can just get rid of the antibody-producing cells, not 100% as much as we can, and this is rituximab. Remember, this was the humanized antibody, okay? Not humanized, mouse chimera antibody, uximab, that is used to treat leukemia, okay? Leukemia being the type we're talking about would be a B cell leukemia or the chronic lymphocytic leukemia that Julia had, okay? All right, again, at a lower dose. Cool. All right, so this right here is showing the steroids doing their thing, okay? All righty, so in comes prednisone, which is a glucocorticoid, binds to the steroid receptor, it goes down there, and it keeps these transcription factors from producing inflammatory cytokines. The steroids get in the way, so we heard all about NF-kappa B. I'm sure you guys heard of FOS in other classes, June, all of them, they don't get access in your T cells, and as a result, the inflammatory genes don't do their thing. Okay, very cool. All right, this is the NSAIDs. Okay, Advil, ibuprofen, Celebrex, naproxen. The way it works is when you have an injury or an infection. Okay, we have damage to the lipids, okay? So these damaged lipids then are then transferred into inflammatory prostaglandin type of messengers by converting the damaged lipid using cyclooxygenase 2 to the prostaglandins, okay? They create pain, that's why we take them as painkillers, and they reduce inflammation, okay? They increase inflammation. So we're going to take a cyclooxygenase inhibitor to keep from this happening, okay? Now, some of them also, okay, can do this, okay? They're non-specific, so you got to be careful not to get gut rot, okay, because you're producing less stomach mucus, okay? All right, so, and you can have some bleeding issues from these cyclooxygenase inhibitors. You should not overdo your naproxen, your Advil, okay? I like Celebrex because it doesn't have the crossover. It's a selective COX-2 inhibitor. Awesome. Okay. And this just kind of goes over the COX-1 and COX-2 pathways. That's too much detail for me. These are your DMARDs, okay? Disease-modifying anti-rheumatic drugs, okay? And what we look at here, when we look at these guys, is boom, 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 boom. Okay. This is, see that AML, anti-malarial drug? That's the infamous hydroxychloroquine or Plaquenil, okay? It reduces inflammation by having this negative impact, as you see right here, on our dendritic cells, our macrophage. That's an antigen-presenting cell that is going to activate our T cells, okay? There, we see we can use methotrexate. It's going to reduce cell division in both these populations. Gold particles have been very, very useful. So there's a lot of these disease-modifying anti-malarial drugs that are modifying the interaction between the dendritic cell, the macrophage, and its presentation of an antigen. Say it's your thyroid cells proteins, okay? Your liver cell proteins, your joint cell proteins, to the T cells and B cells, okay? And when you decrease this interaction, then you're going to decrease all of these pro-inflammatory cytokines, IL-1, IL-16, IL-17, right? All right, so that's the drill on these, okay? So it goes through all these things, and you just kind of read up on these as well, okay? Boom, 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 boom. Again, the infamous Plaquenil, okay? Crazy we had to go through all that for or infection with SARS-CoV-2. Okay, so I did a quick run through the DMARDs and then the biologics, and these are different companies. This one here is Humira. Xeljanz is the Janus kinase inhibitor. Rituximab, you see right here, also called Rituxan, is the inhibitor. It binds to B cells and actually you'll reduce the number of B cells. And this right here is your IL-6 receptor antagonist that we heard about in the Emperor of All Maladies. Okay. Yeah, so that's it. All right. Lots and lots of different tissue affected by autoimmunity. This is my buddy Ken last year and his wife Deborah. They're big clothing manufacturers, and it's just such a bummer. We haven't seen them since. And of course Julia, who's awesome. I love the curly hair. I don't know about you guys. Okay, awesome. All right, so we're done with that one. All right, I'm not going to save that. Okay, and what I'm going to do is I'm going to do a quick run now. Poof, over here to diabetes. All right, because I want you guys to know this. All right, most of your patients you're going to deal with have diabetes. Let's run through glucose absorption in the gut, and then we'll look at the pancreas and how it maintains glucose homeostasis. We'll look at cell responses to insulin and glucose elimination in the kidneys, because knowing all this helps you in terms of the different modalities of treatment that we have. Okay. All right. So right here is our intestines. Okay. And these right here are the villi that are on top of the enterocytes. Okay. If we look inside the cells that line the villi right here, we see we have this specialized exchange protein. It's a sodium glucose transporter. You guys remember from neuroscience, okay? Sodium is pretty low in cells, high outside, so we can use that driving force of sodium going inside the cell, and it brings glucose with it, okay? All right, so that's a co-transporter, all right? All right, and then once that happens, okay, then that's SGL2, then we have another transporter right here that is concentration dependent and transports glucose into the bloodstream right there. That's your gut. Okay, we have SGLT2 down here. Okay, this is in your kidneys. Okay, because it seems silly to just be peeing out all that glucose that you work so hard to eat. So your kidneys undergo this resorption process using this sodium glucose transporter that again will in your kidneys. It's both a SGL2 and SGL1 that will use again the driving force of glucose to resorb sodium, to resorb glucose out of your urine and put it back into the blood. All right, so that's what that's all about right there. Important because that's the new type of drugs that are out there. Okay, all right. So about glucose elimination, the kidneys again, the glucose transporter. Okay, and this shows it right here. This is the kidneys where you're resorbing right there lots and lots of glucose. So if you're a diabetic and you have a high blood glucose, I can give you a protein that will block this resorption. You'll be peeing a lot, okay, because you have a lot of glucose in your blood, but it's going to reduce your blood glucose. That reduces advanced glycation products, inflammation, and a lot of the problems associated with diabetes. All right, so we come down here to glucose homeostasis, and this is a combination of high blood glucose because you had a meal, you pump out the insulin, that's shown right here. All right, and I know this is kind of double dipping because the other one also does it, but you see the insulin right here, okay, gets released when there's high blood glucose, all right, and the insulin then will you see right here, high blood glucose, insulin goes to tissues, says take up the glucose, we know that, binds to insulin receptors, sucks the glucose out of the blood, okay. Glucose falls, it may fall too far, glucose is low, the pancreas senses this and secretes glucagon that goes to the liver and says, by the way, all that glucose you have stored in your liver, time to release it. Glycogenolysis, gluconeogenesis, okay? That's how that works. We're looking inside our pancreas at the beta cells that release insulin. How does that work, okay? We see right here, this is a pancreatic beta cell right here. This would be from the bloodstream, okay, where the glucose has come in, it senses the high blood glucose, okay? The glucose is transported in via the glucose 2 transporter. It gets metabolized, you make a bunch of ATP, and then you have these potassium channels that get closed by ATP. We know from nerve cells that if you close off potassium from leaving the cell is going to depolarize and start firing action potentials. Same thing kind of happens here. What happens is these voltage sensitive calcium channels open up, all right, because of the closure here, because you just had glucose come in and elevate ATP. And when they close, the calcium channels open. It then causes fusion of the insulin containing vesicle, and boom, it gets released right back out there into the bloodstream. Now you have the glucose that's out there along with insulin that's going to go to the muscles. Okay, awesome. One way we can elevate insulin for a diabetic, okay, that's having trouble putting it away, is to give drugs that act on this channel right here. All right, and they're called secretagogues, and sulfonylurea is one of the classic ones. Awesome. Okay, what happens to my cells when glucose and now insulin gets there? We've gone over this in class, guys. Now the only big difference on this is we're going to talk a little bit more again about how we're going to get the glucose inside the cell. We saw the insulin receptor. Okay, this is cell proliferation, Emperval melodies, baby. RAS, RAF, MEK, ERK, transcription factor, cell growth. Okay, we also remember this. PI3K, AKT, mTOR is not in there, but it should be, and all these other different pathways that are going to result in production of new proteins, et cetera, et cetera. At the same time, PI3K is a key messenger that takes these vesicles that have these transporters and says, time to fuse so that we can let the glucose in. Okay, that's a big deal, big deal. All right, and you can remind yourself of all things that happens right here when we have the insulin receptor going. Okay, and this just kind of goes over other things that happen. Okay, we also see a stimulation of amino acid transport in the cells because it's grow, 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 grow. Okay, uptake of free fatty acids, and we actually block the burning of fats. Okay, when the insulin is working. So this is important, right? Because if you get the fat out of the blood, that's going to improve, remember, your insulin receptor sensitivity. Awesome. Okay, we're churning along right here. All right, metformin. Okay, we talked about this drug. Okay, and what metformin does, okay, is metformin inhibits the action of glucagon. Okay, in terms of gluconeogenesis that we see down here and glycolysis. Okay, not glycolysis, gluconeogenesis and glycogenolysis. Thank you. It also improves our insulin receptor sensitivity. So metformin is a win-win for diabetes. Okay, alrighty. This is a cool video where you guys watch the action of metformin. Okay, and these are all the things that metformin does. All right, so metformin, like I said, it's going to block the manufacturing of glucose from your liver. Both gluconeogenesis and glycogenolysis gets reduced by metformin. Okay, remember it's an AMPK activator, right? And that's how it does it. It increases glucose uptake in the muscles, reduces the formation of free fatty acids, so it blocks the burning of fats. Okay, and it reduces intestinal absorption of glucose. The bottom line is when you do all this, you improve insulin receptor sensitivity and you get rid of the high levels of blood glucose, which is hyperglycemia. Okay, awesome. There's our friend metformin again. Okay, I talked a lot about the diabetes link right here. Okay, in terms of AMPK activation, that is going to reduce the release of glucose into the blood by blocking gluconeogenesis and glycogenolysis. Okay, we also know that that metformin is going to inhibit mTOR indirectly through here through its AMPK activation. Right. So this is the good and the excitement that it has an anti-cancer effect right through here. All right, glucose elimination in the kidneys. All right, super important. So this is a commonly used drug for treating diabetes called Farxiga. This would be the blood coming in to the nephron. Okay, remember the glomerulus in your kidneys. It filters the blood, gets rid of glucose and byproducts of metabolism, and you pee it out on this side. Okay, this drug Farxiga blocks the sodium glucose transporter, so you're not taking glucose out of the urine, putting it back into the blood. You pee it out, right? Very cool stuff, all right? Again, this is the concept of the transporter. All righty, mechanisms of diabetes. Why is it happening, okay? So we have autoimmunity for diabetes, okay? All right, so this is an interaction of both genes and environment. There can be an autosomal recessive risk, okay, for both type 1 and type 2. Type 1 is your immune system takes out your beta cells. You're completely 100% insulin dependent, okay? Means you have to have insulin injections of some sort because the beta cells are gone. Type 2, which is the more common adult-related, again, this is genetic predisposition. So if you have a family history of it, you've got to be careful. In combination with the environment, meaning you got to limit the number of carbohydrates in your diet, okay? You want to improve insulin receptor sensitivity. You got to reduce inflammation. You got to reduce free fatty acids, okay? In the end, with type 2 diabetes, you can have pancreatic cell, beta cell failure, and then you're now also dependent on insulin injection. So you don't want to let it get that far along. It is a big risk, okay? This is all about staggering cost of diabetes. It's, like I said, it's insane. 1 in 7 people have diabetes in our countries. This goes through the different types of risk based on your ethnicity. Again, this is showing right here that we have this raging obesity epidemic, and it's plotting right here the rates of diagnosed diabetes per 100 civilians from 1980 to 2014 by age group, and you see that you know, sadly it didn't used to be so bad, but we seem to see this inflection point in the 90s, and off it went. All right, cool. All right, so let's take a look at insulin receptor and sensitivity and what's going to happen here. Okay, now when we have a lot of high fat, okay, right here in our blood, all right, so you're morbidly obese. Okay, what happens is the free fatty acids enter the cell. Okay, all right, and then through this process we see here through ceramides and diacylglycerol, on and on, it actually blocks the insertion of GLUT4 into the membrane, so you can't pull. If you're a muscle cell, you can't pull glucose out of the blood. If you're a fat cell, you can't pull glucose out of the blood. All right. So this is how free fatty acids create this insulin receptor insensitivity. The insulin binds the receptor, but it doesn't do its job here because fat is inhibiting this pathway. Okay. What else do we have here? All right. Important stuff here. This is the natural history of a type 2 diabetic. Okay. This can be controlled. It doesn't have to end so badly. Okay. But over the life course, you go through more and more and more insulin resistance, okay, which is going to be more and more and more elevated blood glucose, okay? And so as the glucose begins to rise, what happens is the beta cells right here, they're doing the best they can, trying to keep with that, and then they begin to die off, all right, because of their hyperactivity that they have. And you have beta cell dysfunction, and now you're dependent on insulin injections. As a type 2 diabetic, not a good thing. All right, boom. So this is the life course that we're looking at right here, okay? So all the stuff let's talk about here, let's now take a look at what happens to our pancreas when we go through this, okay? So here's our an example of a healthy adult, normal pancreatic beta cells. All right, now you're pre-diabetic, you're becoming overweight. The pancreas is pumping out more and more and more. So they get bigger and bigger, more and more cells. They undergo cell division. You know, remember pancreatic cancer is because they undergo cell division. And then you start seeing dysfunction right here, all right? Major dysfunction, and then it begins to die off. And when it dies off, then boom, over here, you stop producing insulin. And now you become an insulin-dependent type 2 diabetic. All right. what happens? Okay, you have when you have lots and lots and lots and lots of glucose, advanced glycation end products, inflammation, your blood vessels stop working correctly, okay? And you have what's called vascular disease that results in complications all throughout your body. The most obvious one is heart disease, stroke, deep vein thrombosis. The blood vessels in your eyes go bad. Blood vessels right here, diabetic retinopathy. The blood vessels to your kidneys go bad. Diabetic peripheral neuropathy is a way out. Nephropathy is your kidneys. Neuropathy is again because of really poor circulation out in the periphery. And then it's clear that Alzheimer's disease is part of diabetes. 80% of Alzheimer's patients have diabetes. 80. And then we learned all about obesity, IGF-1, insulin receptor activation, and cancer. So we know that it's not good for any of that. All right, so down here, how are we going to test it? We're going to test with glucose test, fasting blood glucose, okay? Should be below 100 or less, okay? Glucose tolerance test, 140 or less, okay? Hemoglobin A1C, okay? And this is the level of glycation of your hemoglobin proteins. It's the best readout, and that's why doctors look at it the most, okay? This goes, again, some verbiage on that. This is where we're at. So you want your, on a percentile basis, your A1C should be about 5 or less. You get about 6.5, you're a diabetic. This is pre-diabetic. Again, this is fasting glucose. You want to be below 100, all right? If you're in this range, you're pre-diabetic. You're above 125, you're a diabetic. And then the glucose tolerance test, where we give you a known amount of glucose, and these are the cutoffs there. Again, you should be 140, where we give you a sugar tolerance test. If you're in this range over here, you're pre-diabetic to diabetic. Awesome. So this is, again, this concept of glycation, all right? Elevated blood glucose, because you're a diabetic, then glucose fixes itself to proteins, including what? Hemoglobin, all right? And that's what the hemoglobin A1C or HbA1c test is looking for. Symptoms of diabetes, okay, let's just run through this and with the explanation, okay? Why do these symptoms exist? So you have so much glucose in your urine that the water follows, okay? And so you're peeing all the time. So you're urinating often. You feel thirsty because you're peeing all your fluids. You're hungry because your insulin receptors don't work, so glucose is not getting into cells. You have fatigue, again, because the glucose is not getting into cells. That's what this is all about right here. We have lots of vascular disease, okay, and this is advanced glycation end products and vascular disease that cause problems in terms of cuts and bruises. Weight loss, tingling, on and on and on and on, okay? Awesome. All right, so again, why do these symptoms exist? Let's look at this. This is the best figure ever, okay? But look at the blood glucose in the middle here, okay? So we see right here that elevated blood glucose causes advanced glycation end products. It binds to the receptor for advanced glycation end products that causes major inflammatory protein release as well as platelet activating proteins. What else happens? High glucose results in reactive oxygen species synthesis, oxidized LDL, and the whole process of atherosclerosis that you're going to learn in more detail in 414. Okay, not good. And this again is everything that we kind of discussed in class that leads to everything we saw here. Okay, boom, 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 boom. Some reading, all right, for you. Okay. Again, this shows you the range right here. Advanced glycation products, just kind of look at it. It's a trip how much you guys know, okay? Really cool animation, actually animation and discussion about a guy that has the complications arising from diabetes, and then this looks like kidney function diabetes. Alrighty, cool. More and more and more here. Alrighty. So for diabetic retinopathy, okay, we use Avastin. Remember, vascular endothelial growth factor. Same thing we use for cancer. We can use it for your eyes. Lucentis is the other drug name. It is basically the same thing. Costs about 10 times as much, and it was a big deal. Okay. Alrighty. What else do we have here? So this is a list of all the types of drugs. Okay. insulin and time-release insulin, insulin sensitizers, okay, insulin receptor sensitizers, metformin, yeah, secretagogues that increase more, okay. We can slow the digestion of glucose and entering into your blood. This one's a cool one called incretin. When you eat a meal, sugar's coming in, your gut says, hey, guess what, pancreas? Here it comes, and it releases these two factors, GLP-1 and GIP, and they both increase the amount of insulin get released by the pancreas. This is an animation about time-release insulin. You don't need to see that here. We talked about metformin, okay, which improves many things, okay. So it's an insulin receptor sensitizer as well as reducing the amount of glucose produced by the liver, okay. I'm just going off on here. I just want you guys to see it here. And then this is, again, another sensitizer that is used, all right. And that's called thiazolidinines, okay. All right, cool. Secretagogues, okay. So these are the sulfonylureas that block the potassium channel. So that means you're going to produce a lot more insulin release, okay. This one slows digestion, absorption at your intestinal microvilli, right? And so it outcompetes glucose there. And this is looking at the incretin, okay? Again, this is when you take in some glucose, okay, from a meal, tummy and intestines, they release these factors right here that go to the pancreas, and they cause a super release of insulin, all right? And this right here is the increment effect, which is really, really cool. You guys can kind of look at this in more detail on your own. But if I were to give the same amount of glucose in your blood on the green line as what enters your blood from a meal, so the blood levels are exactly the same, the difference is when it enters from a meal, you get a lot more insulin because of your GI system releasing the incretins that go and prime the pancreas. Okay, so that's your incretin effect. This is just, again, talking about how they work. All right, and then back to these guys. We're going to block the resorption of glucose in our kidneys, and so that's a whole different level of diabetes care. All right, again, I put this out here. No free lunch. Sometimes there's problems. You can read the label. Okay, and then amylin. Okay. Lastly, if you have insulin, not enough insulin being released, okay, and so there's no insulin that goes to that's the key that goes into a lock that says open up and pull the insulin out. Then your cells are like, I need nutrition, and they go acutely into super major fat burning in ketosis, right? Now, it's okay in the short amount that we did it, but if it's long term, you get ketoacidosis, okay? This can happen in both type 1 and type 2 diabetics, by the way. More likely, of course, in type 1, but it's a huge risk factor, okay? Because the acidosis that we see right here can cause coma and can cause many of your organ systems to shut down. Okay, so it's a very, very vicious cycle, and yeah, anyways, I want you guys to kind of look into that, understand it, and boom, that's where we're at. So it was a lot, but I did it all for you because I love you guys, okay? All right, so no worries, that's our lecture on diabetes, and what I want you guys to do is kind of now relax, and don't forget, I'll be doing the core and stretch tomorrow, first thing in the morning, not first thing in the morning, 2 o'clock, all right? Cool. 2 o'clock Monday, Wednesday, Friday for the rest of your life. Peace, guys.